Hi, my name is Sheila and I'm one of the PT wound care therapists. I am doing a video for you guys today on how to effectively chart wounds in iView. I know that y'all work overnight and it's very hard for us to get our information out to you guys, so I'm going to do a little video. And I've also got a nice little handout that I'll provide for y'all. So the reason I'm doing this is I'm doing my clinical ladder and I just kind of want to explain how to chart correctly in iView. I don't think it's something that people have really gone over with the nurses. Basically, iView is actually a tool used to quantitatively chart information about wounds. So once we put it into iView and start a wound in iView, multiple providers can chart on that wound during the patient's admission, and it just carries on, so we can see kind of how the wound progresses or changes. When you see a wound on a patient, please enter it into iView and upload photos of the wound to Compass if you're able to, using the Camera Capture app. Charting on the wound once a shift is sufficient. You could do that if you're doing a dressing change, or if you're just doing it to assess the wound, you can do one entry into iView. If there is a notable change in the wound or drainage or dressing, you can do another entry. So what you're going to do is you're going to enter the wound under the Wound Incision Skin Abnormality tab. You will enter the wound location and type of wound. So please be mindful of the anatomical location of the wound. Try to put ankle if it's the ankle and not just the foot. Put medial, lateral, kind of use those descriptors to help really identify the location of the wound. And when you're doing something like the sacrum or coccyx, try to make sure that you're using the correct anatomical location of it. A lot of times we'll get sacrum, but really it's the coccyx, and especially when we're looking at pressure ulcers, it's nice to have a more accurate description of where the wound is at. And then also make sure that what you're entering into iView isn't a duplicate. A lot of times we see that there'll be left leg written up at the top, and then you scroll down and then there'll be like left lower leg, and it's really the same wound. So you're going to also fill out the discipline managing the wound, and I think this is really confusing for nurses. So the discipline managing the wound is the actual people that are managing the wound care or managing the wound. So is it the surgeon? Is it PT wound care? Is it nursing, or is it like a combination of it? So when you guys chart on a wound or the dressing, it's not that you're actually managing that wound, you're just putting in information in iView about that wound. So it's really helpful to know who is managing that wound, because if there is an issue, it helps to go to iView and you can say, oh, it's PT wound care managing this back, I'm going to call them. And then also, if you know what surgical team, you can fill that in too. You can say plastics or team A, surgery oncology. And then normally if it's a VAC, a lot of people think that it's PT wound care, and it is mostly us, but sometimes the patient's VACs are being managed in the OR. So if it's a surgical team, it's best to call them first if you have an issue with it. They may tell you to contact us to come help fix something, but it is nice to know exactly what surgical team is managing it. The next thing is wound etiology. If you do not know why this patient has a wound where they have it, you can just put wound of unknown etiology. So, and note too, we get this a lot of people put surgical incision for the wound instead of an actual surgical wound, and those are two totally different things. Surgical incision is something that's sutured or stapled. Sometimes a VAC may look like it's an incision, but it's really an open wound with the foam in it. And if it's a pressure injury that was present on admission, then you'd put community acquired, and if it was not, you'd put hospital acquired. If you are not sure if it's a pressure injury, you can just put wound of unknown etiology, but please make sure you get an order for PT wound care. We'll come assess it, and we can put the appropriate origin and stage it as necessary. Anytime a patient has a hospital-acquired pressure ulcer, either PT wound care or WCN needs to come and stage the wound and take photos. For the description of the wound, sometimes you guys are just able to see the outer gauze. So if you can't describe the wound, you can just say unable to assess, dressing is clean, dry, and intact. If you are able to, I've actually put some descriptors, like if you're actually changing the dressing, I have some descriptors listed here for y'all to use. I won't go over those in this video, but I'll let you kind of browse over them, and I've included some pictures. Another field which we kind of commonly have addressed wrong in the IV section is wound drainage. If you're assessing wound drainage, you want to note, is it min, max, serosanguinous, purulent. If you cannot see the dressing on, you can't see the drainage because of the dressing, then you say unable to assess. This field is not really asking for how much drainage you're able to see on the dressing. It's actually trying to find out what's draining from the wound. But usually when we have a dressing in place, you shouldn't be able to see it. Now, if you have a wound vac, you actually can see the drainage. It's in the canister. So if you want to put min, serosang, or whatever you see, serous fluid, and I know there's a different place that you also chart that in your line section, so you could put it there. I don't think you necessarily have to put them in both places. If you want to just do it in your line section, but you could maybe put like the type of drainage that you see under IVU. So that's pretty much kind of the basics of IVU for wounds. The reason why it's helpful for all of us to be charting the same thing is so that, you know, if you have an audit or something, it's nice to see that, okay, like, you know, either there was like a very accurate way of telling how much drainage there was. Sometimes it'll be like none, and then we'll come behind and we'll take it off and we're like, oh, it's, you know, moderate purulent drainage. So we're just trying to get everything a little bit more consistent. So if you guys have any questions, my name is Sheila Choksey, and you can Volt me or send me an email, and I can answer any questions that you guys have. Anyways, I think that's it. Thanks a lot.